Hello, my name is Zach Jenkins, and I'm an associate professor of pharmacy practice at Cedarville University and a clinical specialist in infectious diseases. And in today's COVID-19 discussion, I'd like to focus in on where we're at with testing for COVID-19 within the United States. At the time of this recording, there are almost 700,000 cases of the coronavirus that have been identified worldwide. And there are a number of other tests that are actively pending. And we do have a fair idea that this is not nearly representative of the number of people that are actively infected right now. And so we're going to continue to see this number increase as more people get infected, but especially as more people are getting tested. One big thing that's changed in the past week is the United States has actually surpassed both China and Italy as having the most number of reported cases worldwide. And so how that's played out for us, to date we have over 120,000 cases, over 2,000 deaths, and over 3,000 people that have recovered from this virus. So if you were to add up the recoveries and the deaths here, you'll see we have just under 6,000 people that have completely had some resolution of this infection. So we have a large number of people out there that are still actively infected at this point in time that we know of. And we also know there are a large number of people that are probably carrying this virus that may not even realize it. So this is where testing is going to become really important to consider. One big thing we've talked about a lot in the past is this idea of the epidemiologic curve. And we know that at some point the peak is going to occur. And so what you see here in yellow again is if we didn't try to mitigate the spread of that infection, that's what that would look like. And then in the purple down here is what happens when we do mitigate the spread of that infection. So we've done a lot to flatten the curve, to delay the onset of when this peak does, and to decrease how high that peak is. But one big thing we talked about last week is what we're doing to raise the bar. So how do we increase the overall capacity of our healthcare system so it isn't overwhelmed? One thing that can impact to some degree is testing, and we'll be discussing that here in just a moment. But before I get into that, I'd like to kind of show you a practical example of how social distancing has actually improved things. So using the Ohio Department of Health's data, we know that our projected peak would have actually been here towards the end of March here. And at that point in time, it was thought we would have had over 40,000 cases reported per day in Ohio, which would have greatly overwhelmed the number of hospital beds that were available, knowing that somewhere between 20 to 25% of those patients would have required some sort of hospitalization. Since we've instituted a lot of these social distancing efforts, we've actually seen that peak be delayed, but also decrease in how high it would grow. And this data is actually pretty representative of what both the Ohio State University as well as the Cleveland Clinic have compiled as far as what our projected peak might be and approximately when we might see that. So at this point in time in Ohio, we're now expecting the peak to hit sometime in mid to late April. Some projections are saying maybe even out into early May. But the point is we've delayed this onset, and now we have an opportunity, since we bought ourselves time to raise that bar, to increase our healthcare resources. So what you don't see here is what that bar is. And the Ohio Department of Health has actually stated they will be representing that here in the future when they have a more firm idea of what we're working with. But how does testing really influence this model? So we'll talk about that here in a second. But when we think about testing, more than likely, you've actually heard a number of different things that have happened with testing in the United States. How there have been failures, how maybe we were delayed, how do you get testing? There's been a lot of controversy surrounding this, so we're going to get into this in great detail here. The big thing we have to really focus in on first is what is the importance of testing. And as you can imagine, the most important thing that we think of right away is it influences how we approach treatment. Now, as I've shared before, the virus itself looks a whole lot like other respiratory viruses, like RSV, like influenza, like metapneumovirus, and a lot of those symptoms can be shared when we think about respiratory infections. It also can look like bacterial infections of the lungs, and on top of that, it can look like non-infectious respiratory diseases, such as heart failure that's worsened or chronic obstructive pulmonary disease that's worsened. And so up front, our providers are really faced with this challenge of differentially diagnosing people, of determining which type of disease or infection a patient may have. And so knowing accurately who has COVID-19 greatly influences how we would essentially manage those patients from here on out. We would know whether they needed an antibiotic or not. And of course, we know COVID-19 patients don't really need antibiotics because it's a virus and not a bacteria. We would know whether they needed to be isolated more uniquely etc. So it influences those aspects. Another thing to really think about is this does influence these modeling projections, as I mentioned. So let me illustrate this in a couple of ways. If we know how many people actively have the virus, as well as maybe the locations of these individuals, these communities of people, we're able to more accurately gauge how rapidly this virus can spread. There's a concept out there called zero prevalence. And what zero prevalence really is it represents the number of people who have had the infection or currently have it, and also who doesn't have that infection. And the problem is we've not really been able to determine what the zero prevalence of this infection is because we've not had access to antibody testing. So with antibody testing, we're able to know who's actually had the infection. Another thing that's been a limitation is we haven't been able to scale these tests widely yet, and so that's also influenced our modeling. So if we know who actually has the infection, another thing that's going to help with our modeling is it'll tell us what our projected peak height may be. It'll also influence our determination of how to allocate resources, and I'll talk about this in just a second. One thing it does determine, though, is how our community responds. So if we know a particular locality has a large number of coronavirus infections, it'll probably be expected to have those individuals increase social distancing efforts, or we'll actually even have those people kind of quarantine themselves to not infect others. So we'll be able to better respond in that sense. On the healthcare resources side of things, not only does this help us figure out how to use resources within an institution, it also helps us to think about how do we operationalize our national resources. So as I discussed last week, we had the Strategic National Stockpile that was deployed by the government to help mitigate some of these issues that we're seeing in the field. And so they've been deploying ventilators and other equipment and medications, etc., to localities to deal with a large number of patients. So if we happen to know a community has a higher number, because we're testing that community more, we're able to more accurately determine what the need of a region might be for whatever resources we have available. So for all these reasons, testing is very, very important. So to give you a practical example, if we look at Ohio, we know that our hospitalization rate seems to be holding at about 20 to 25% of all patients. So if we actually break this down further, and we look at how we're using specific resources here, in this case hospital beds and ventilators as an example, we know what our capacity is and how much we still have available versus what's unavailable. So if we can actually more accurately test people, we'll be able to determine whether or not we can anticipate using more or less of these resources, as well as how to accurately determine, even within a state, for example, where we should be pushing more of these resources specifically. So how has testing looked like for us in the United States? So I'm going to show you two diagrams, and the first thing I want to preface before I describe these is these are over a week old. So this was the most recent data that I had available collectively. But you can see here that there were over 100,000 cases, or 100,000 tests that were performed in the United States. And if you contrast us with South Korea had about 3 times the number of tests that they've actually distributed in their country to date. And they're a much, much smaller country. So why is that? Well, in South Korea, if you looked at how the coronavirus has spread, they were able to successfully contain it. They haven't had to institute the same mitigation efforts, the same social distancing efforts that we have had to in the United States. And the reason for that is if you look back in the early 2000s, South Korea was one of the Asian regions hit most hard when it came to the SARS outbreak. And so as a result, they had actually developed some protocols in place to rapidly deploy testing, or to determine how to build a test, for example, as soon as they had a first case drop. And so when they had that first coronavirus case reported in South Korea, they mobilized all those resources rapidly. Now, in contrast in the United States, when we look at H1N1 and SARS, we weren't really hit by those very heavily in contrast to the rest of the world. And while our emergency response system has actually been hailed globally as being one of the best in the world, this was a major oversight on our system's part, because we hadn't necessarily set up the ability to rapidly develop and deploy tests on this kind of scale before. So this has actually led to a slowdown of our tests, and I'll kind of show you what I mean by that here in a moment. If we take the same diagram, then we break it down by 1 million people per test performed, you can see that we have about 313 or 313 tests performed per million people in the United States. So obviously there's a great opportunity to increase our testing capabilities, knowing we have 327 million people within the United States. What I will say is, based on the most recent data I'm aware of, we've actually performed over 500,000 tests as of today. So those testing capabilities are increasing rapidly now, and there's a lot of reasons for it that we're going to talk about. So what's really happened with our coronavirus testing, and why have we been delayed? Well, our first case of the coronavirus was reported back in early January in Washington State. And in a couple of weeks later after that, the CDC had actually been developing a test to identify this organism. And they ended up sending that testing information off to the FDA to determine if it could be approved to mobilize this test. Now, the FDA and some other entities have received a lot of criticism when it comes to how things have been handled. I think the current administration has received a lot of criticism for the delay in the development of these tests. So what's important to realize is that the FDA, as of 2004, has had standards in place that require certain conditions to be met for a test to be used for diagnostic purposes. And the reason is we want to limit the ability of a test to overdiagnose or underdiagnose patients with a given condition or a given infection, for example. And so as a result of this, there's a process that these people have had to go through to get a test approved. So Stanford University in February ended up developing a test to detect the coronavirus, but the FDA actually held that up in regulatory processes because, as I mentioned, they've had these things in place since 2004 for purposes of tests being high quality. So we look at February 4th, and that's where the FDA first finally approved the official test that we were going to be using in the United States, and the CDC was the one that developed that. Unfortunately, about a little over 8 days later here, we actually had a reported failure on a wide scale of these tests. So the CDC came out and publicly disclosed these tests had failed. So what they were seeing in Seattle when they were testing people was that they had a large number of people that were not testing positive and that maybe had it, and a large number of people that were testing negative when they did have it. So that was a big problem with these tests. So a couple weeks following that, the FDA ended up relaxing some of these regulations that they've had in place, which allowed laboratories to develop and use tests before they had full approval by the FDA. So that streamlined the process to some degree. And I'll be providing you some examples of kind of where we're at with regards to that to date. But what I want to do is discuss what our different testing modalities have been up until this point. So the three big things we've been using for testing for the coronavirus within the United States have been the reverse transcriptase polymerase chain reaction test, or RT-PCR. I'll be calling it PCR for short. The antibody test, which is very new. And then we've even been using imaging like CAT scans. And so I'll be breaking these down individually and talking about some of their pros and some of their cons. But in order to do this, it's really important for us to discuss how viruses really replicate. And so what you actually see depicted here in this image, this is actually a cell. And you see this circular object here, which is a virion, which is a piece of the virus. And so this virus is actually entering the cell through this mechanism. And what viruses do that's different from bacteria, viruses actually take over the machinery of the cell. And so they actually cause the cell, rather than to perform its normal functions, to just do nothing but make more virus. And so the virus makes more of its genetic data. In this case, when we think about the coronavirus, it's RNA. And that genetic data is actually used to influence what the cell does as soon as the virus enters. So it actually gives specific written instructions for a cell to perform certain functions. In this case, making more genetic data and making more proteins with the virus, which the virus uses to help build its structure. And so these things get replicated in mass. But one thing that happens when the virus enters the cell is, if you kind of look on this diagram here, you'll see that we have these different black spiky things sticking out of this virion. And those actually represent proteins. And so those proteins end up getting left on the surface of the cell. What they allow this virion to do is to bind to the cell and end up getting absorbed by the cell. So then that virus can replicate. But pieces of it get left on that surface. And this is going to become pretty important later when we start talking about immunity, because these are antigens. These are kind of what trigger your immune system to form antibodies ultimately. And that's going to be important for testing here in just a moment. But the other thing to really pay attention to is as this virus replicates and makes more genetic data, there are all these different viral particles that float around. Specifically, that genetic data is floating around. And so the antigens and the antibodies that ultimately get formed to it, as well as just genetic data, are key targets when we think about how to test for whether or not this virus is present. So speaking specifically to the PCR test, so what this does is this actually takes genetic data from the virus, in this case it's RNA, and they actually collect specimens from patients to find this RNA. So what they do is they actually will insert a swab into your nasal cavity to get a specimen that way, or they'll actually collect sputum, and they can even collect things from the base of the lungs in more serious cases to get that sample out. And what they do when they get it in the lab is they take out that genetic data and then they duplicate it over and over and over and over again. And when they have so much of that genetic data present, if it happens to have a certain sequence on it that's been pre-selected by the test manufacturers that is unique to, in this case, COVID-19, it would actually cause that test to come back as being positive. So there's a probe that's actually in this genetic sample that would actually flag as being positive in those cases. But they have to duplicate enough of this sample first in order to be able to detect whether something's present or not. So this is what a polymerase chain reaction test is. So another test that we have available are CT scans, and we'll talk about why we even thought about imaging in the grand scheme of things, because if we had this other test, why would we resort to this? But CT scans or CAT scans really give us an image of the lungs, and they can determine whether there are any kind of abnormalities there. So a really well-trained radiologist could read one of these scans, and they could say, well, this patient has an abnormality in the lungs that shouldn't be there. They have tissue damage maybe, or they have fluid collection in a certain region of the lungs. And so based on that information, they can determine whether someone maybe has like a likely pneumonia, a viral infection, some kind of other respiratory disease of some sort, etc. So this helps us identify whether something's wrong with the lung. And if you look on these images here, you have shots of both sides of the lungs in these patients. And what you should see in both of these cases, it should be mostly black if the lungs are actually pretty empty, because your lungs are filled with air. But what you see here is lots of gray area in some cases. Like on this particular image, you see a little pocket of gray matter there, which probably represents fluid of some sort. So if you see stuff there that isn't black, that's a good sign something's wrong. And a radiologist can narrow down and say it's this specific kind of thing. So the problem with these imaging tests is while they help us rule things in, the possibility of them having some kind of infection, they don't really tell us what specific infection a person has. So they don't help us truly rule something out or even differentiate what specific virus it might be or bacteria it might be. So that's a major limitation of this kind of testing. So then the question is, why were we even using this? Well, in China, according to their treatment guidelines for COVID-19, they were really encouraging the use of that PCR test up front. But because there were issues with transporting the test, with keeping it safe and undamaged, etc., what ended up happening is the tests that were initially used were only positive 30 to 60% of the time in patients who actually had the virus. That was a major, major problem. And so as a result, they had to supplement it with other things like imaging to help with the diagnosis of these patients. And what they found is that the CT scans compared to these early PCR tests were a lot more sensitive, meaning they could detect something when the other tests really couldn't. More recently, we've had the development of some more novel tests that we're using in practice now. We're trying to deploy rapidly in practice. Specifically, there was this rapid IgM or IgG combined antibody test. So this is an antibody test, and what it's doing is it's identifying the presence of specific kinds of antibodies for COVID-19, and I'll talk about how that works here in a second. But the question is, what is IgM and what is IgG? So these are types of antibodies. They're immunoglobulin M and immunoglobulin G. M is something that occurs early in early stages of infection, and G is kind of what we think of more as long-term immunity. So the idea behind this kind of test is it tells us who actively has that infection and maybe who's had it in the past and is either actively developing immunity or has fully developed immunity. So both of those things can really help give us a better picture of what's going on with our patients. So how this antibody test ends up working. If you remember earlier when we talked about a viral infection, there were those antigens that were present on the surface of a cell, those proteins that got left behind when a virus came in. And so what happens then is your immune system detects those and through a lot of different mechanisms ends up developing antibodies. So what these antibodies do is they actually have the ability to bind or to grab on to those specific proteins that they see. And so that allows your immune system, as these things get flagged by antibodies, to appropriately respond and get rid of the virus. So if a patient's actively been infected before, you should see this complex form between these proteins, these antigens, and those antibodies. So the test is actually looking for that complex, that new molecular entity that gets formed by that binding of those two things. So if it's positive, it means at some point the patient has had this particular virus. And what they're able to further differentiate is which kind of antibody it is. Is it IgG or IgM? And this again tells us if it's short-term immune response versus like a long-term immunity that we're dealing with. So what's important to think about with any of these different tests is it sensitive or is it specific? And so what do these terms really mean? So I liken it to a needle in a haystack. And sensitivity is being able to find anything in the haystack. So if you have a test that isn't sensitive at all, you probably can't even look at the haystack. You're unable to find anything. If it's really sensitive, you can look in the haystack, but that's all it tells you that you can do. You're really good at finding things in the haystack of all sorts, but not specifically the needle that you may be looking for. In contrast, you have specificity. And what specificity is it helps you determine whether you really know what that needle looks like or not. So if you have a test that isn't very specific, you're going to be not only finding the needle, but a whole lot of pieces of hay. If you have a test that is very specific, it's very good at finding that needle. So ultimately, you want to balance between these two things, because what this helps us do is eliminate a great degree of patients who may have a false negative result, meaning they actually have the virus and they're detected as being negative. And you also want to prevent people from having false positive results, where it tells them that they have the virus when they actually don't. So you want a good balance between these two entities. So if we kind of compare where our different tests have been to date, the CT scans that have been done are really, really sensitive, as that other study kind of showed you. But again, it doesn't help us know what specific thing we're dealing with. It just says something's wrong. So they're sensitive, but they're not specific. We won't know it's the coronavirus. We can only know that maybe 1 in 4 times based on this data. So on its own, not so good for ruling out, but it's helpful for ruling in that there may be an infection. When we look at the PCR test, there are a lot of complaints worldwide, and certainly within the United States initially, that it wasn't very sensitive. And actually, sensitivity reports have ranged somewhere between being 60 to 71% of patients being detecting those patients. So what that means in practicality, roughly we'll just round up and say, or I guess we'll pick in a middle number and say 1 in 3 patients who had the virus would actually come back as being a false negative. So that's not something we want to see happen. But this test has been fairly specific, but if you still kind of look, 1 in 10 patients potentially on the more pessimistic side may have come back positive when they didn't actually have the virus. So there's some limitations there as well. So this test is really good for ruling out because it's more specific, meaning it's better at identifying that the virus is there, but it's not very sensitive. So you kind of have to use this in concert with some other things that we have available. More recently, that we've had this antibody test that's been deployed. And so this has a sensitivity of 88.66% and a specificity of 90.63%. So this has a better balance, as we've kind of discussed. And so that's really good for ruling in and out. But what's especially helpful about this test is it can differentiate stages of infection. So if you remember earlier when I was talking about zero prevalence, this kind of testing is going to really help us figure out who's had that test who's had the organism in the past and maybe doesn't actually have an infection right now. So what does this mean for us looking forward? So the FDA has really ramped up its efforts with approvals of different testing equipment, with decreasing some of the regulations in place, etc., to try to incentivize people to rapidly get these tests on the market. So that's been one big thing that's been developing and has really led to some successes I'll share with you here in a moment. The other thing that's happening is we're seeing an increased access to testing more and more every week, and so we have to really focus on operationalizing that. We've had some limitations with the supply chain even when it comes to manufacturing tests, so that's created some challenges. But now we're starting to mobilize more and more companies to produce more and more varieties of tests, which will increase access and ultimately will help increase the overall number of people getting tested. And the last thing that we've seen is really a spur of innovation as far as how to best approach things. Some of our early PCR tests would take maybe a full day to completely resolve before we knew whether someone had a positive case or a negative case. But the new things that are coming out are getting results back in a much, much shorter period of time. So one thing that's been kind of being deployed now is this idea of drive-through testing. So in order to increase the throughput, the amount of people that they're able to get a test, people have set up these drive-by testing locations where people will wear protective equipment. They'll have you only roll down your window when you're getting the test in your vehicle, and they'll swab you right there. And in some of these cases, we now have point-of-care tests that are on-site at a location, which allow us to give you results pretty rapidly. So this helps prevent spread by having people kind of interact with each other unofficially in groups as they're trying to get tested. And it also makes it pretty efficient because people just drive up, they get their test, and they leave. Now, one thing to keep in mind here is you can't just drive up anywhere. You actually still need a doctor's order. And so that's been confusing for a lot of people. One thing that's really kind of helped recently, though, is on the 27th, Abbott Labs actually received FDA approval for its point-of-care test, which actually is something called nucleic acid amplification. And I won't get into too many great details about this. Suffice it to say that this is very, very rapid and effective. So it's sensitive and it's specific, and it can turn results back in as little as 5 to 13 minutes. It's reported that you can get a positive result back in 5 minutes and confirm that it's a true negative within 13 minutes. And Abbott's trying to ramp up production of these tests since it was approved, because they can produce about 50,000 tests currently a week. But again, if we want to have rapid access to this test, we want to deploy this readily. A nice thing about this test is you don't have to send it to a lab, and one of the big limitations we've had with testing is a lot of these things have been send-outs where we haven't been able to do it on-site. So I'll give you an example. In my healthcare system right now, our coronavirus tests that we're able to send out at my institution take anywhere from 3 to 7 days to come back. And so that's time when a patient's still being managed like any other respiratory case. Maybe they're being hit with the kitchen sink of treatments, so to speak, because we don't know what they actually have. So if we're able to determine faster what someone has, again, we can respond more appropriately. So what's great about this test is it's point of care, meaning you can actually do this on site and get results back right there. So this is a great innovation that hopefully we'll actually see really rolled out on that national level. So the last thing I want to kind of end on here is many people are asking, when should I get tested? So the first thing to really think about is, do you have the symptoms? And if you don't know what those are, if you don't know how this stacks up compared to other respiratory illnesses, and you don't really want to go to a doctor necessarily, the first thing I'd encourage you to do, unless you have severe symptoms, is to log on to coronavirus.gov. There's a screening tool and a screening app actually that they've developed with Apple to try to more rapidly have people self-assess whether they need to seek medical treatment. So what I would say though is, if you're symptomatic, talk to a physician, call their office, ask what to do. They'll direct you what the next step would be. Just remember, to get tested, you still need a doctor's order. If you do have more severe symptoms like trouble breathing, you have persistent chest pain or pressure, you have new confusion that wasn't there before, you kind of feel foggy when you didn't before, or if you have some sort of a bluish tinge to your lips or your face, those are again more signs of a severe infection. And in those cases, I'd skip the website, I'd skip calling the doctor, and I'd go right to the emergency room, because you probably need immediate medical attention, whether it's the coronavirus or not. It could be the flu, for example. So with that, I'll end today's discussion. In the future, I'll be trying to detail things like treatments and some other developments that have really occurred within our efforts in the United States. Thank you all.